of potentially treating patients with severe mental illness. And we think that potentially 10 to 15, perhaps even as much as 20% of people with psychosis may be suitable for this completely novel treatment. Okay, so coming back to novel treatments for depression, so Mike Browning, again my colleague, a more targeted, more sort of successful approach to the bedside, to patients who really need to get really into the mechanistic understanding. So this is the work that Mike has led, so again starting with healthy volunteers, working out using fMRI tasks, how the pramipexole impacts on the brain, and in this case it was a reward learning task, and using a computational modelling before and after. So having done this for 4 nations, and within our mood disorders TRC work stream, we now have, I think it's 15 specific clinics which are going to be staffed for treatment-resistant depression, able to recruit from both primary care and secondary at the moment. And again, just to show how we can get this through to impact. So not just the repurpose, but also industry studies coming through, building on this model. In the last few minutes, I just wanted to highlight slides, and he sent me bullet points that I needed to highlight. But basically, the main point is that the deaths from opiate overdose haven't gone away. There's a huge increase, and it's still increasing. So significant rise in opiate-related overdose deaths over the last decade. And with the King's CRF, with that sort of, which basically involves, in a controlled setting, precipitating an opiate overdose in both volunteers and in patients, and then being able to devise ways of rescuing, so really directly impact saving lives. So two of the things, and this is a graph of just sort of respiratory rates, and so you could see the long pauses 5 minutes after an injection. And two of the ultra portable fast dispersible naloxone, so something that can really work in an acute setting. And then of course, as Paul said, I'm from Birmingham, still closely linked to Birmingham, and I really wanted just to highlight the amazing support that for my own work that we've had from the acute CRF here in Birmingham. We've been running this study for just over 2 years, and we're recruiting patients with schizophrenia from the community who have evidence of inflammation into a experimental medicine study where they have a one-off infusion of tocilizumab, because our sort of observational and epidemiological evidence suggests that IL-6 is particularly important in the inflammatory profile of patients with schizophrenia, as well as collecting sort of non-immune active, clear relationship between grey matter volume loss and that peripheral markers of inflammation. And this is work that we'll then be able to take forward into more targeted experimental medicine study population. So, off my soapbox, but we have to see how much work we have to do to address these challenges. And there's really exciting science that we can do. There's really exciting experimental medicine that we can drive through to validate these targets. BRCs really strong much.
Health. And I think Joe's passion, as you'll see, is for addressing health inequalities. He leads several flagship programs, but today he's going to talk about the NIHR Maternity Disparities Challenge and its collaborative efforts and future goals aimed at ensuring equitable maternity care for all. Joe.
So thank you, Paul, and good afternoon, everybody, and thank you for the opportunity to speak today. It's especially meaningful tackling maternity inequalities and also disparities. To the right slide. Collaboration isn't really just part of the solution, it ultimately is the solution from my perspective, and that's what I'm going to spend a bit of time just talking about now. So my name is Joe, I'm here on behalf of the Maternity Disparities Consortium, which I co-lead with Judith Rankin from the University of Newcastle, and we've got a huge contingent of members. We are a new UK-wide initiative designed to tackle persistent disparities in maternal and neonatal outcomes. I'll just spend a little bit of time just focusing on the background, because I know that we know some of this, but actually the political will is changing in the world. So I think it's really important for us to still really hammer home quite how important this topic area is. Some really stark statistics here. At the end of the day, black women are nearly 4 times more likely to die during or after pregnancy than that is co-produced and embedded in real world services can really make that difference. Sadly, these aren't just isolated cases, so these are patterns. These patterns are ultimately structured, systematic, and deeply rooted in who gets heard, who gets accessed, and who gets care that truly meets their needs. Too often, those who are at the most risk are also the least likely to be part of research. They're the least likely to be asked what matters, and are also the least likely to be involved in shaping services. And that's why our consortium, and I know a lot of other infrastructure, also represented them in mind in the first place. So this chart from Embrace, from my perspective, really paints an absolutely devastating picture. It compares the care of Asian, black and white women whose babies have passed away, and the disparities are both clear and absolutely persistent over time. Black and Asian babies are significantly more likely to be stillborn or die shortly after birth than white babies, and this community is affected, which is why the principle of the consortium and also a lot of the work that we're going to be doing now is thinking about systems change going forwards. And I'm just going to put into context what that slide before really meant. So between 2017 and 2021, if black and Asian babies had experienced the same stillbirth and neonatal death rates as white babies, 1,704 babies would have actually survived. And ultimately, from my perspective, that number should absolutely shake us. 5 years. So this Disparities Consortium is the first NIHR Challenge Award. From NIHR's perspective, they recognise that this isn't a problem that can be solved through business as usual research. It ultimately leads really bold, large-scale collaboration across universities, NHS, local government, third sector partners, and like I mentioned, communities themselves. What is it that we're trying to achieve? Well, first, we want to build the evidence base that drives action and leads to better outcomes. Second, we want to develop the next generation of researchers who understand inequality and equity and how to work across systems. And third, we want to transform not just what research we do, but ultimately how we undertake that work as well. So this is a call to shift the entire approach in this particular field, and collaboration is ultimately the way that we get there. So our work is going to be guided. It is absolutely built on the principle that no single institution or discipline can fix this alone. But just to explain a little bit about what the structure of consortium looks like, it's a UK-wide initiative, and there's 18 universities, 4 companies, councils, local authorities, trusts, charities, NHS partners who are involved in this program. Just to give you a flavour of our West Midlands partnership, which is led by the University of Birmingham, we've got over 110 different collaborative organisations. So this consortium, if you think just on that scale, we've potentially got 9 collaborations with approximately, and the one principle that we do like to remind everybody about this is about putting the ego out the door and actually putting what's important first. And ultimately this slide is so anybody's in these things, we need to think about focusing in that space as well. So how did the consortium actually get to the plan of what we're going to do? What was this journey of collaboration? So we ultimately had to effectively a 9-step journey in that path. We began by mapping priorities, not just the academic agendas, but by listening. We ran a lot of regional engagement events across the whole country. We surveyed communities, we aligned with existing policy. And ultimately, the crux of what we're trying to get to is this was like, we've got a huge number of people involved leading the different themes, and I'm going to spend a bit of time talking about what they are. But we've got partners from all around the UK actually taking part. We took a very, very, very shared leadership approach. Can very families of birthing people access care in time? And does that care feel safe, respectful, and culturally appropriate? So this is looking at issues like late booking, poor quality communication, language barriers, fragmented. This is an opportunity actually for everybody, even those outside of the consortium, to apply to. So this is going to be a nationally sort of open space for those interested in work in this space. And we're also going to be that last but second box on that ResNet. We're going to be developing a research network about maternity and inequality.
Thanks, Joe.
I think it is. Can you hear me? So obviously with a short amount of time, what I haven't been able to do is really show the extent of our PPIE, both within the BRC and specifically within the TRC. So neurostimulation. Obviously the context and the history of mental health and mental illness research is complicated and is an extra challenge for researchers within our field, and an extra challenge for people who are working within PPIE experts by experience within each one of our themes. And the best way to answer the question is, do you have to have PPIE from the start? co-designing your study, even if that was a very small-scale experimental medicine study, which I think that we do.
Thank you, Rachel.
Asking but not assuming. So we often tend in clinical practice actually to assume where we see the inequalities might last, why they are, why they're happening. We might look at somebody and make a judgment or an assessment actually based on just what they look like, where they are, where they're from, and then think about what's best in their interest, but we don't often take that moment to ask. I know that many people do actually, and I'm very grateful for those who do, but that's something which has come up a lot time and time again from a lot of our mark on it, whether it's research or whether it's clinical practice. So actually there's a moment for all of us just to reflect on and think actually, what are our implicit biases that we're bringing into this consultation, into this engagement, into this experience, and actually how might that affect the relationship, and actually what could the outcomes of that be? That's something in there. The third thing that I just also wanted to say is I think tackling inequality is something which everybody has the best will in the world to do. There's absolutely, I don't know, I mean, if somebody has they want to widen inequalities, it's a broader issue, but most things we try to do, most innovations we try to bring on board, Agora Sultani in Sheffield and Debbie Smith from Manchester, but I'll hand over to Rachel.
Well, I think also we obviously need to talk because within the sort of Oxford VRC and within the context of women's mental health, because obviously the perinatal period is of specific risk, but we know, and it comes back into sort of the representation that women's experience of severe mental illness, schizophrenia, is very different in terms of the epidemiology, the onset, the sort of peaks, around menarche and then menopause, as well as postnatally. So there's a lot of work to do, but a lot of interest in that area. An hour-long lecture on this, if I had time, because the stigma that our patients have, stigmatised within the medical profession. If you say you want to go into psychiatry, people still say, oh, well, that's a bit of a waste, could you not do something better? That's something that I've heard being said to medical students within the last couple of years. So it's so pervasive, this stigma against